guys, we're back with another episode of 25 Days to Question Your Induction with Improving Birth Abbotsford, reading from this book, Why Induction Matters by Dr. Rachel Reed. If you have missed the last several videos that we've been doing in our series, the first one is on the stats for Fraser Valley and for Abbotsford Regional Hospital, which has the highest rate of induction in all of BC at 31.9% as of the 2015-2016 statistics. You can verify that yourself at Perinatal Services BC. You can go into their surveillance and reports, and their facility level indicators is where you can find the induction rates for all of the hospitals in BC that have maternity care. If you haven't seen our informed consent videos, those are the next three in the series, and I encourage everyone to watch the informed consent videos because they are incredibly important. You need to know what informed consent is and what it isn't so that you know the difference. If your care provider is not giving you full informed consent, then they are not doing their job. And it could be considered coercion that they're pushing you into an induction that may not need to be done. We also have a video on brain, benefits, risks, alternatives, intuition, now or nothing. That is another way of making decisions, and we can find out what questions we want to ask. And then the last one is the decision-making framework. And the decision-making framework is taking into account how this is going to affect your birth vision and what you particularly want to do, what's important to you. Then we have our complications series. And if you have a variation of pregnancy with a complication, then you need to go and watch that video as well as watching the variations, because a variation of pregnancy with a complication is a little bit different than a variation of pregnancy without a complication. So we have the hypertension, preeclampsia, and gestational diabetes in the first of our videos for complications. The next video is on pre-existing diabetes and intrahepatic cholestasis of pregnancy, ICP, or cholestasis. Then after that, we have a trigger warning on our video. It's for reduced fetal movements, preterm, pre-labor rupture of membranes, and stillbirth. So if you want to skip that very last one that we did yesterday, you are more than welcome to do that. I'm not going to be offended. So now we're going into variations of pregnancy. And I just wanted to point out that, again, the risk of a stillbirth after 41 weeks is 1 per 1,000. It's less than 1%, guys. It's 0.1%. And it'll go to 0.3%, so 3 per 1,000 after 42 weeks. And it'll go to 0.5% or 5 per 1,000 after 43 weeks. So, yeah, the risk does get higher, but it's still less than 1%. And if you're a first-time mom and you don't have any signs of labor and you have a very low Bishop score, like under 6, you have a 50% chance of having an emergency cesarean. And I say emergency in the sense that it wasn't planned. It doesn't mean that it's an actual emergency. If it's an emergency, you're going to get knocked out. Like, there's no time to discuss it. But if they're saying, well, you know, we're going to get you prepped and you'll have your cesarean in like an hour from now or 30 minutes from now, and they're not rushing, it's not an actual emergency. It's they're seeing something wrong coming up, and it's likely because the Pitocin is something the baby's not tolerating, or the contractions are too strong because they've broken your water, or any of the other cascade of interventions. That's why we have the cascade of interventions images, and we talk about the cascade of interventions a lot because it's true. You intervene with a physiological process when baby's not ready to come, and you're likely to get a complication. It's one of those things that if you have a complication of pregnancy and you want to reduce that risk, then the risk of the complication developing from the induction may be worth it to you. Or if the risk of the complication is it's just a variation, it may not be worth it for you to derail your entire birth plan and think about an induction when that risk is so small that you probably would just have a spontaneous vaginal birth in a few days anyway, and you don't need to go through that for yourself. I'm one of those people that if the risk is less than 5%, I'm not going to do it. I just don't want to put myself through that. Other people, they may have different ideas. It's like, well, I just can't take that risk, and that's fine. If you just can't take that risk, that's fine. But telling everybody that this risk is too high and I'd rather have the C-section than a dead baby is what people say. That's not informed consent. That's a little bit bullying to say that. And it's not kind. It's not a kind thing to say. Other people can see that as, oh, gee, they think I'm selfish because I don't want to induce. Maybe I should induce. That's kind of what happened with me, is that I got so worn down because people kept saying, you're being selfish here. It's not about you anymore. It's about your baby. Don't you want a healthy baby? Just do it for your baby. No. We're going to do better, guys. We're going to do better. So, I'm the troublemaker. I know I'm a troublemaker. I'm pretty sure doctors hate me. But the ones that actually practice informed consent will love a patient or a client that actually sees themselves as a decision maker, because that takes the pressure off. It's easier to talk to somebody who's informed when you want them to be informed than it is to talk to somebody who's just like, oh, well, just do whatever you do. And then they get upset because something's not going right. And they're like, well, you never told me that. And it's like, well, you didn't ask, and you didn't seem like you were very interested in your care, which isn't okay. They're still supposed to do informed consent. But our system is broken, and we don't always have time. That's why Improving Birth Abbotsford is here, so that you can get your information, because a lot of the time, the care providers don't have time for it. The midwives love us out here because we're able to inform women, so we're making their jobs a little bit easier, so that they can have their clients come in already somewhat informed, and then they can fill in the blanks for them. So, post-dates pregnancy is different from a post-term pregnancy. A post-dates pregnancy is after 40 weeks, and it's not an emergency, because a 40-week due date is not taking into consideration that term is 37 weeks to 42 weeks. Now, the Perinatal Services BC Stats considers a post-dates pregnancy anything after 41 weeks. Which, okay, that's good. But what about the women that go to 42 weeks naturally? I have two of them. Christine and Wendy, they go past 41 weeks. It's average for them. And if it's average for you, then it's probably okay. If you have a complication, then you probably want to look into that too. But for post-dates pregnancy, post-dates just means past your due date. It doesn't mean even past 41 weeks. And then we have the post-term. Post-term is different than post-dates. If you're going post-dates, your risk of stillbirth is a lot lower than if you go post-term. If you go past 42 weeks, it goes to 3 per 1,000 for the stillbirth rate. Still not very high. And if you happen to be a 42-week gestation and your family goes to 42 weeks, then chances are that's just normal for your body. And the risk of stillbirth is probably much lower for you, because that's just how long baby needs to gestate. So it says Before modern science, women used the moon cycles to track their menstrual cycles and estimate when their babies would be born. Women expected to give birth within 10 moon cycles, not 9, 10. And that takes 295 days or 42 weeks. And then since the 1700s, attempts have been made to estimate specific due dates. So basically when the doctors all decided to come in and treat us like machines and say, oh, well, everybody has to go around the same time and make everything predictable, when are our periods always predictable? Do we know exactly when we're going to start our first period? I didn't know that I was going to start my period until I was 16 and a half. Everybody's like, well, that's not normal. But it was normal for me. I was a tiny person. Other women, they start their periods at 8. We all grow at a different rate. And sometimes, even if we have a 28-day cycle, we don't ovulate right on day 14. Or baby might take longer to implant in the uterus than what is typical in the textbook. And we labor differently. We all have different labors. Our labors are not textbook. Nobody is going to follow the textbook 100% of the time. So when I look at the idea that all women are supposed to do this by this point, I shake my head, because that's not at all taking into effect our own biological factors and our own physiology, how we are made up. We're all individuals. So they used the 40 weeks after the first day of the last menstrual period. And then in the last decade, dating ultrasound scans have been routinely offered to women at 10 to 13 weeks. Dating scans attempt to calculate the gestational age of the baby, and based on that, estimate the date that the baby will be 40 weeks. So again, they're basing this on 40 weeks. Only about 35% of women give birth before 40 weeks. I think it is. We'll have to keep looking in here. However, estimated due dates based on ultrasounds at any gestation are no more accurate than the estimated due dates based on the last menstrual period. So even if you go for a dating ultrasound, that's still not a guarantee that they know what your actual due date is, even if they go by the conception date, because babies all grow at a different rate. So research has clearly shown that the average pregnancy does not last 40 weeks, and only 35% of women give birth the week of their estimated due date. So it's the week of your due date. I'm not sure if that's the week before you hit 40 weeks or the week after. But basically the week of your due date is 35% of women. That's not all women. That's 35%. For women having their first baby, pregnancy lasts on average 40 weeks and 5 days. And 75% will give birth spontaneously by 41 weeks and 2 days. That's why I say mostly that's like 41 weeks and 2 days to 3 days. Because by that point, 75% of women will already have gone into spontaneous labor by then. But the actual average is 40 weeks and 5 days. My son, I went into labor at 40 weeks and 6 days. So it seems kind of average. That seems accurate. And it's quite possible that I was in early labor the day before. And then I went into active labor the next day. Because I tend to have like 2-day long labors before things get really picked up. And then it says 75% will give birth spontaneously by 41 weeks, which we know. A number of other factors are known to influence how long the individual pregnancy will last. So ovulation, as I said, doesn't always occur on day 14. Embryo may take longer to implant into the uterus. Woman's diet may influence the pregnancy. And there's also the genetic factor. Babies that go longer tend to go in families, either on the mom's side or the dad's side. So you might want to look at that and see, well, who else in the family got induced? And before that, in the 70s and 60s, who went longer? I am very, very, very lucky because my grandmother said that she had pretty much a 10-month pregnancy, almost 11 months. But they also didn't have a very good estimated due date, and they could have been off. They didn't have dating ultrasounds back then. But she went what she felt was way, way past her due date, almost a month. And that could have been typical for me, but it wasn't. I just get the prodromal labor, and it drives me crazy a little bit. But then there's Christine, her family, I would say, from what she said and everything, is that they have later pregnancies. And she has small babies, smaller than mine, and they're healthy. So that's just typical for her. It takes longer for babies to get the fat they need to be up to almost 7 pounds, but still like 6 pounds. Like she had tiny babies. So then it says a woman who has her first baby after the estimated due date is very likely to have her subsequent babies after the estimated due date. So if you had a late pregnancy, like later post-dates pregnancy with your first, that might happen again, or it might not. But if it does happen again, it's normal for you. It does not mean that you have anything wrong with you, and you don't need to induce. If you had an induction the first time and you really did not enjoy it, you don't have to do it again if you don't want to, and there are no risk factors. So here's what the evidence says about induction for post-dates. Induction for post-dates pregnancy is primarily offered because of the general rate of perinatal death. Now, remember again that it's 3 per 1,000 after 42 weeks. But the hospital obviously doesn't want that statistic in their files. So, while the increase is statistically significant, the rate remains under 1%. For example, the perinatal death rate, as I already said, 0.1% at 40 to 41 weeks, 0.3 at 42 weeks, and 0.5 after 43 weeks. Now, here's the Cochrane review. A Cochrane review found that induction of labor before 42 weeks reduced the perinatal death from 0.3 to 0.03. And this finding is the primary reason for the recommendation of induction for all women with post-dates pregnancies. So yeah, the rate is reduced, but again, the original rate is under 1%. So the reason for the slight increase in the perinatal death rate in the post-dates pregnancy is unknown, and current research focuses on general outcomes on what happens rather than why it happened. So there's some doctors that believe it's because the placenta is failing. But if you're normally gestating to 42 weeks, you can check out your placenta afterwards, and there's a lot of women that have super healthy placentas even at 43 weeks. So the thought that the placenta automatically starts to deteriorate right at 40 weeks, it's not really backed up by anything, because if you go into the home birth communities, you can see that there's hardly any calcification in some of the placentas. And that doesn't necessarily mean that the placenta is breaking down or that it's not functioning. So others suggest that these changes are due to the aging and deterioration of the placenta, but the placenta tests of placental function show no change in post-dates pregnancies. So they have actually tested this, and there's no change. In addition, most babies continue to grow after 40 weeks, suggesting that they continue to receive adequate nutrients and oxygen. So you can't have it both ways. If a doctor says, well, the baby's going to keep growing and get big and the placenta's going to fail, that doesn't make any sense. If baby's not growing, it's because there's something wrong with the placenta. So which is it? And as it says, placenta can not be a problem at all. And babies getting bigger may just be something important that they need to do because they're less than 5 pounds at 40 weeks and they just pack on all their weight at the end. It's just, you got to take that into consideration. I mean, like I said, 42 weekers had smaller babies than mine. And babies were healthy, so the placenta was perfectly healthy and functioning. So after that, studies that identify an increased perinatal death rate for post-dates pregnancies do not identify the placenta as the problem. Another possibility is that the increased death rate may be due to complications with the baby, and that the pregnancy can cause a delay in spontaneous labor happening. So it's more that there's something wrong with the baby than there is about the actual problem with the placenta. And there's no way of really knowing whether the baby would have the problems because they're overdue or that they're overdue because they have the problems. So you have to basically think critically about that. The Cochrane review found that a third of the perinatal deaths reported in this study review were due to pre-existing congenital abnormalities. So they did find a link between congenital abnormalities and a post-dates pregnancy. But for the vast majority of women, a post-dates pregnancy is a normal and healthy individual variation. It is difficult for individual women to determine if their post-dates pregnancy is normal for them or whether they will experience a rare complication. So that's where the better safe than sorry attitude kind of comes into play. But in the case of if you've already had a post-dates pregnancy and your baby was fine, then chances are that's just normal for you. If a woman has previously experienced a post-dates pregnancy without complications, there is no increased risk of perinatal death. Or, I just have to turn the page, or any other type of complication if they wait for spontaneous labor. If the woman has not previously had a post-dates pregnancy, it might be helpful to consider what is the normal gestation for her family. So, now we're going to go into spontaneous post-dates labor. Around 90% of women who choose to wait for spontaneous labor will give birth before 42 weeks. And only 1% will remain pregnant after 43 weeks. Most guidelines recommend additional monitoring for the baby's well-being. So basically you'd go in for the non-stress tests and the ultrasounds. However, no form of antenatal monitoring reduces the chance of complications. Women also need to consider the impact that this is going to have. As I mentioned in the informed consent videos, if the additional monitoring is just going to cause you additional stress because you're with a hospital that is very much, let's just induce this baby, and they're going to be talking into your ear, you may want to consider either going to a different hospital to have your monitoring done or monitor yourself. You could monitor your blood pressure and get a Doppler. Or you could say, I don't want any monitoring because I know my baby's fine and I'm just going to go by movements and my intuition. And that's a valid choice. There's women that do that. Basically, any choice that's going to work for you. Anxiety does not help with oxytocin, guys. So when I was very, very anxious about getting labor started, that's when my labor would stall. And I was very anxious with my first pregnancy because I was terrified of getting induced. So that could have been why I went to 41 weeks, because I finally had it clicked in my brain that I'm not going to go into this hospital until I'm good and ready. And that's how my son was able to come. But having extra stress and being told, well, when are they going to induce you? When are they going to induce you? You know, the risk of stillbirth goes up. And having that in your ear over and over again, it's very stressful. So if you're one of those people that finds that having people talk in your ear is going to mess with your head too much, you can choose not to monitor or cut back on the amount of monitoring or find a different care provider to monitor you. You can also find a different care provider. That is within your rights. And if you're the type of person that feels reassured by those monitoring and will be like, oh yeah, my baby's fine, I'm okay, then you might want to do the additional monitoring. For me, having the additional monitoring reassured me that I didn't need to induce. So I kept going in for the additional monitoring, mostly just to show everybody that everything was fine and to show myself, it's like, see, everything's okay. Because I didn't know all the stuff that I know now. I didn't know about the stillbirth rate. I didn't know about that until I talked to my midwife at West Coast Health Collective back when I was pregnant with my daughter, and I talked about how the stillbirth rate goes up, and she's like, well, it's actually only 1 per 1,000. And I said, that's it? She's like, yeah. And it goes to 3 per 1,000. I'm like, really? That's it? And she's like, yeah. And you can go to 43 weeks with no problems. Really? Yeah. So we had a lot of really interesting conversations. I loved my pregnancy. Abigail, I love you. I miss you. So anyway, so for women, monitoring can reduce the stress and assist with oxytocin release. Because if you're relaxed and knowing that everything's fine, you're more likely to not have problems with your oxytocin levels. The best indicator of baby's well-being is their movement. Women with concerns about baby's well-being should be encouraged to pay close attention to their baby's movements, regardless of whether they choose additional monitoring or not. So just pay attention to your baby. When I was in labor with my daughter, and I had the prodromal labor, through every contraction afterwards, she would make little kind of movements with her hands against my cervix and just do a little kick. And that was kind of, I felt that was kind of her way of saying, I'm okay, Mom. You can keep laboring by yourself. You're fine. So that's what I did. And she was very active right until she was born. So listen to your baby. Your baby is in tune with you. There's a few factors associated with post-stage pregnancy that may alter the experience of spontaneous labor. Post-stage pregnancies tend to be bigger because they continue to grow in the final weeks of pregnancy. Now, this may not be true for you. Babies may just get bigger at the end. You might just have a 6-pounder at 42 weeks and have a 4-pounder at 40 weeks. So big babies rarely cause problems during labor unless the woman has poorly managed gestational diabetes. If you don't have poorly managed gestational diabetes or pre-existing diabetes, because that's a chance too, then the big baby thing, not really an issue. The reason babies get stuck a lot of the time, get off your back. Seriously, get off your back. This whole birthing on your back thing, you're pushing uphill. And baby doesn't have the ability to move around in the pelvis because your pelvis is not open. On all fours is the best idea, or squatting. Get into the position that's most comfortable for you during labor. Follow your body. That's another reason why with an epidural it kind of messes with things, because you can't feel anymore what your baby's trying to tell you and what positions you need to get into. For me, for most of my labor, I needed to be on all hands and knees. And then near the end, when it was time to push, I had to lean back in the water with my daughter. And I didn't do the pushing. My uterus did the pushing. And I needed to be in that position because I knew that I was going to have a high tear if I didn't. But that's listening to your body. So there's also the chance of lower levels of amniotic fluid at 40 weeks. But again, this is not necessarily true. You may have very normal fluid levels for your gestation. During labor, the amniotic fluid protects the baby, the placenta, and the umbilical cord. That's why I don't really suggest breaking your water unless there's an actual reason to do it. Because it's like, look at a water balloon. If you have the water balloon and you're squeezing it, all the water pressure is equalizing, isn't it? And it's not as likely to pop unless, of course, you throw it. And baby's kind of protected and cushioned. And it says here, a healthy post-stage pregnancy can cope well with some compression during contractions, particularly if there's enough time between contractions to recover. So with a physiological birth, you're getting a break with those contractions. And the way it works is that your body does the contraction, baby responds, and it comes back to your brain and your body signaling, okay, do we do a stronger contraction this time or a less strong contraction? So my contractions are very, very irregular with my labors, but it allows my babies to turn because they start out occiput posterior, OP, with their head turning the wrong way and their back turning the wrong way, and it can give me back labor if I don't have those signals to my body telling me to get into certain positions or to have a less intense contraction for this one. So physiological birth is a lot different than an induced labor. It says here, in an induced labor, there's even less amniotic fluid because part of an induced labor is breaking the bag of waters. So then you've got the pressure squeezing, and you don't have the feedback from your body to from your baby, letting your body know, because pitocin doesn't cross the blood-brain barrier. So that's probably part of the reason why induced labor is so much more intense, is because your body doesn't know that it's that intense, and that can lead to fetal distress. And it can also lead to bad positioning because the contractions are just pushing the baby down but not really taking into account the baby needs to turn. Amniotic sac usually breaks towards the end of a spontaneous labor, in my case crowning. And in post-dates labor, there's more likely to be meconium in the fluid. Now, here's about meconium, because I hear about the aspiration of meconium quite a bit, and people are scared of that. So, meconium is made up of mostly water and a number of substances including amniotic fluid and intestinal cells. So, at the end of the pregnancy, the baby's bowels are filled with meconium. We know about that. But let's get to the part where the actual meconium, the rates here. Meconium-stained amniotic fluid occurs in 30 to 40% of pregnancies after 42 weeks. So it's not all pregnancies. You might not have any meconium. So the theory is that it means baby's distressed. However, the connection between meconium and distress has not been proven. Most babies who become distressed in labor don't pass meconium. And most babies who pass meconium show no signs of distress. So, based on this theory, all babies that are known to pass meconium, they have observation. Many care providers believe that meconium-stained fluid can cause a condition called meconium aspiration. MAS, or MAS. MAS is thought to occur when a baby inhales meconium-stained amniotic fluid into their lungs during labor, resulting in problems with breathing and or infection of the after birth. However, a baby will only inhale deeply enough to get fluid into their lungs if the oxygen supply through the placenta drops to extremely low levels for a longer period of time. So that's more likely to happen in an induced labor with your waters broken than it is to happen in a physiological birth where you've got your waters intact and the pressure's equalized and there's no compression on that placenta. So that's something you might want to think about. This situation is unlikely to go undetected if the baby's heart rate is listened to regularly through labor. So if they're monitoring you with the Doppler or with the CTG, if you're stuck in bed with the monitors, they're going to catch that. The diagnosis of MAS is controversial, though, because the symptoms of MAS can also be found in babies who did not have meconium-stained fluid. This leads some research to question whether the symptoms are caused by meconium aspiration or whether meconium happens to happen at the same time as MAS. MAS is more likely to be diagnosed in babies born after 41 weeks, and that's a 0.7% chance. So 7 per 1,000 compared to babies induced before 41 weeks. There's no difference in the rate of admission to a special care nursery between babies born in spontaneous labor compared to an induced labor. This suggests that post-dates babies who have problems at birth that are diagnosed with MAS because meconium is present, whereas induced babies with the same problems are given a different diagnosis. So many hospital guidelines recommend the use of the continuous fetal monitoring, the CTG machine, to continuously monitor the baby's heart rate post dates. Guidelines also recommend continuous monitoring if meconium fluid is seen, regardless of gestation. These recommendations are based on common practice rather than researched evidence. So this is just something they do. It's not based on any evidence. And actually, CTG machines are not very accurate at assessing whether a baby is distressed or not. In most cases where CTG is classified as abnormal, the baby is fine. Therefore, CTG monitoring increases a woman's chances of having a cesarean significantly without improving the outcome for her and her baby. National Institute of Health and Care of Excellence guidelines, so the NICE guidelines, recommend that care providers should not offer CTG monitoring to women with non-significant, so meconium stained liquor, unless there are other risk factors. So if it's just a little bit stained, that's not significant. If it's like green or darker than that, significant meconium includes the presence of dark green or black, thick or lumpy meconium. So it would have to be a lot. Instead, NICE recommends that care providers should listen to the baby's heart regularly using a handheld device so you can keep moving around. Because if you're strapped to the bed, you're not able to move around. And labor can be more painful. It actually is more painful, even spontaneous labor. I was strapped to the bed in early labor with my son because I had all those non-stress tests. I did not know that would have happened. If I'd known that, I probably would have known that I could decline. But I didn't know what I didn't know, and those 20 minutes were very, very painful. I had to shake my leg through contractions, and these were early contractions because I was stuck on my back, and of course I had back labor too, so it wasn't fun having that. So that's what it says about the spontaneous labor. And we're now at 36 minutes. But now you know what about post-dates pregnancy, and I encourage you to share this video. And go and pick up this book, Why Induction Matters. Order it online. Get it in. Read it. It's fantastic. Read the blog, Midwife Thinking. Go and read our 25 Days to Question Your Induction articles. I've shared a few of them onto our Facebook page, and you can try to find more. You'd probably have to use a computer for now. But Midwife Thinking does a lot on spontaneous labor and the difference between spontaneous and induced. Sarah Wickham also has something, 10 things I wish every woman knew about induction. We did have that in our 25 Days to Question Your Induction, but I don't think I've shared it just yet. So I'm going to sign off for now, and we will pick up in the next part on advanced maternal age, because that's another one that tends to have a lot of inductions that are otherwise avoidable, and a lot of cesareans being done that are preventable. Our focus isn't on getting rid of cesarean, and it's not our focus to get rid of induction. It's to reduce the amount of unnecessary inductions and unnecessary C-sections, preventable C-sections, because it's costing our healthcare system money. It's causing health problems for women and babies. It's contributing to a difficulty in being able to establish breastfeeding because it's interfering with our oxytocin levels. It's causing birth trauma. It's causing postpartum depression. And it's making it difficult for women who have had a cesarean to be able to find a supportive care provider for a vaginal birth after cesarean. And there's a lot of information out there that's being passed around that's not evidence-based, that's kind of influencing these decisions, that then women come back and they find out that the complication that they have with their second pregnancy could have been avoided if they didn't have the cesarean with the first. And the cesarean with the first may not have been necessary if they hadn't induced. And they didn't actually have a complication that required induction. It was just, well, I went past 40 weeks. And they aren't told that the average is 40 weeks and 5 days, and that 75% of women will go into labor spontaneously on their own by 41 weeks and 2 days. They're not being told that. And they're not being told that you can go to 42 weeks and be perfectly fine and your baby could be perfectly fine. And this is a problem. And we are in the middle of a cultural shift, and there's a lot of backlash, just like there was a lot of backlash with any other feminist movement that has happened in the past for women's rights. And this is a feminist issue. So share these videos, get this information out there. You may get backlash for it, but it's better to get informed than it is to continue to ignore this, because we're not getting any better with our maternity services. We're getting worse. And I'm seeing cases of doctors actually trying to push midwives out again and saying, well, these women need to be in hospital, and they're not going to the hospital, and we're losing business. Well, the reason they're losing business is because women have started to realize we want our physiological births back. And we deserve to have our physiological births back. We deserve to have our empowering physiological births. So if an induction is avoidable and it's not necessary, you can say no. You can. And if you're already scheduled for an induction for a few days from now, or tomorrow even, and you have just found out all this information and you're like, wait a minute, I'm not comfortable with this anymore, it's not too late. You can still say no. You can call up the hospital, you can call up your doctor, and you can say, you know what, I've changed my mind, I'm not going to do it yet. I'll think about it again in a couple of days to a week. It's your decision. Bye, guys.